Good afternoon, everyone. First, I want to thank the conference organizers for inviting me. This is quite an honor to be here in your beautiful country. Second, even though I'm giving a talk on cervical cancer screening, I'm only going to show you one cytology slide. Because as you'll see, I and many others are convinced that as we move forward in the future, Pap screening, what I grew up on, is not going to have as primary a place as it does currently. So for my disclosures, I've worked with a number of the companies that develop or have developed cervical cancer screening and management diagnostic tools like Hologic, BD, and Roche. And then I've also worked with a couple of companies that are developing therapeutic HPV vaccines. So not prophylactic HPV vaccines, but therapeutic vaccines. What I'd like to do in the next 40 minutes is talk about cervical cancer prevention. And that's primary prevention with the HPV vaccine, incredibly successful vaccine, and then secondary prevention, which is what we all work with trying to prevent cervical cancer by identifying precancers so that women can be treated appropriately. In that context, I'm also going to talk about screening principles that apply not just to cervical cancer screening, but to any screening test that we use in medicine. And then how do we, as we move forward in the 21st century, integrate HPV testing into that paradigm? And then my vision of what's going to be in the future. So I started in this business 30 years ago, and I think the way it will be 30 years in the future will be very different than the way I started. First off, cervical cancer prevention is absolutely crucial. With primary prevention with the HPV vaccine, we have essentially the power to eliminate HPV-associated cancers or reduce them so much that from a public health perspective, screening will not be a worthwhile adventure. In the Western Hemisphere, the majority of countries have introduced HPV vaccination. The United States started in 2006, Brazil more recently in 2014. And if we look, though, at vaccination in both countries, the United States has an opportunistic program, very similar to our Pap screening program. We do not have an organized program in the United States. Brazil, more on a national rollout, getting more and more of the same target age young people before their sexual debut, where the vaccine is the most effective. In Brazil, the girls, again, you started in 2014, and it was later rolled out to the boys last year. The United States, again, we started with the girls first, and later the boys were allowed to get the vaccine. In the United States, again, this opportunistic program is marginally successful. We only have modest rates of vaccination, even though it's covered under most insurance plans, with an average dose, first dose in both girls and boys, being about 60% coverage. Now, from what I could get from the literature, in Brazil, you're doing much better. When you rolled out the vaccine, you had nearly 100% coverage of the target age population of girls with the first dose. So congratulations. That is phenomenal success. The boys are still lagging behind, but again, you're only in your first year or so with the boys. We know that the vaccine targets the highest risk HPVs. Clearly, HPV 16 and 18 are the baddest actors, the worst actors in cervical carcinogenesis. They cause 70% of the cervical cancers combined. If we add in the other types associated in the 9-valent vaccine, type 31, 33, 45, 52, and 58, we can potentially cover 90%. We could potentially prevent 90% of the HPV-associated cancers. Now, that's not just cervical cancer. It's also anal cancer, about the 50% of vulvar cancers that are caused by HPV, the high percentage of the oral pharyngeal cancers that are caused by HPV, the penile cancers that are caused by HPV, etc. So we can have an amazing public health impact if we successfully vaccinate our younger population, our next generations. But stepping back, when we're talking about secondary prevention, the Pap smear has been the best cancer screening test that we've had in medicine. The best. Better than any kind of lung cancer screening, endometrial cancer screening, we don't have ovarian cancer screening, any other cancer screening test. And it's led to, in countries that have successful cytology programs, it's led to a dramatic drop in cervical cancer, primarily because we're identifying precancers and treating those women so that reduces their risk of developing cancer now or in the future. And the test is pretty much how Dr. Papanicolaou, developed it way back in the 40s and early 50s. The changes have all been relatively recent, with liquid-based cytology starting first in the mid-90s, computer-assisted screening, and now with the advent of HPV testing, both to assist cytology and in the future as the primary screening test. So all those developments have been exponential, much more recently than the life of the Pap test. If you look at screening cancer, cervical cancer screening in the U.S. and Brazil, we have a lot of similarities. We're targeting the same age of women. In general, we're screening every 3 years, and our target coverage is about the same. A couple of the caveats are, in the United States, most of our PAPs are liquid-based cytology, and in women over the age of 30, the majority of them are being tested both with a PAP and HPV simultaneously, which is what we call a co-test. Even giving our very, stringent attempts to prevent cervical cancer, and sorry, I keep popping my P's here, cervical cancer remains a big problem in both countries. We have nearly 13,000 women diagnosed with cervical cancer in the United States, over 18,000 here in Brazil, with rates that are very high, 16 per 100,000 in Brazil, of essentially a preventable cancer. Mortality rates mirror that, with almost 8,500 women dying annually here in the country of Brazil, and 66,000 dying in the United States. And what's even more tragic in both countries, cervical cancer is the second leading cause of cancer-related deaths in women in childbearing years. Again, entirely preventable cancer. And these women are dying when they have young families to take care of and feed, and those children being left alone. A very interesting study was recently published. This is a 2018 study that was published looking at trends of cervical cancer screening in Brazil. And if I can go, no, it's not there. One of the conclusions of this study was that even with the best approaches that we have, we're falling short. And I'd say that this is true in the United States as well. The majority of cervical cancers in the United States are in women who are not screened on a regular basis. But that leaves about a third of them who are still getting screened or entering the medical system where the system fails. Either they don't get recalled for an abnormal screening test, they don't get treated appropriately, maybe they don't even get diagnosed appropriately on that screening test. If we look at what the WHO says if we're trying to do cervical cancer prevention, in countries with cytology, the cytology has to be of the highest quality and continue to be of the highest quality. And the entire program has to be efficient so that women with an abnormal screen are recalled and triaged to the appropriate next diagnostic, like colposcopy, and then treated if they have those high grades. But that's a multi-step process, and many times women can fall out of that system for no fault on their own, or sometimes because they can't get back in for the next step of the triage. So with HPV vaccination, which is, I think, our primary goal, we are going to, as cytologists, essentially be victims of our own success. Cytology is going to become much more challenging as the prevalence of HPV disease decreases. We will not recognize it as early. What we know most is HPV 16 disease. And if we wipe out HPV 16, yes, please, I hope we do, we're going to have more of a problem evaluating disease. So Pap tests are morphology-based screening. All of us in this room as cytologists are visual people. So how many of you have picked out the face amid the coffee beans? So that is our job as cytologists, to identify rare cells. But then once we identify those rare cells, we also have to interpret them. So do you see one face, two face, or a vase, or all of the above? So all of those things come into a morphology-based screening, and that's one of the challenges. The human brain is an amazing thing, but it also allows for a lot of inter-observer variability. So as we move from the 20th century model of morphologic interpretation, which has a lot of subjectivity, at least in the United States, we're right now in this middle road where we're using morphology and more objective tests, such as HPV testing. But in general, we're going to be moving to the 21st century, which is basically using primarily objective tests with less subjective interpretation involved. So we're going to be moving away from Pap testing. Again, as the prevalence of HPV disease drops in the population, our task as cytologists is going to become exceedingly difficult. Now, many countries are already starting primary HPV screening, both in Europe and elsewhere. Australia, as an entire country, changed over to primary HPV screening in December. As you may know, they have also one of the most successful vaccination programs. And they had a couple of years of preparation to to get ready for this changeover. And it took quite a lot of retraining because they were already set up for doing cytology screening. So what do you do with all the cytotechnologists who have been, their majority of their careers have been looking and screening very effectively Pap slides, when there's going to be many fewer of those now? So we have to reimagine the workforce. The United Kingdom and France and Italy are also undergoing this transition. And where primary screening with HPV is going to be the most important, I'd say, is probably everywhere. So it's in countries with successful HPV vaccination, and more countries around the world are vaccinating their young people. Countries with little or no screening, and cervical cancer remains right up there with breast cancer worldwide as being the leading cause of mortality in women. And also in countries that are entertaining, maybe their socioeconomic level is increasing, so they're entertaining cancer prevention methods. But if they do not already have a cytology program set up, it's going to be very difficult to develop that in the case of dropping HPV prevalence. I have the good fortune of being involved with one of the International Agency for Research on Cancer. It's a subdivision of the World Health Organization. They have a study called ESTAMPA, which is in 10 Latin American countries, looking at primary HPV screening. We're still in the midst of follow-up, in some enrollment, but in follow-up as well. And it looks like primary HPV screening will be very successful used in the Latin American countries. There's a lot of resistance to change in the United States, as there is elsewhere in the world. But most recently, the U.S. Public Health Service Task Force has draft recommendations for changing the paradigm of how we screen in the United States. Still the same target age group, about 21 to 65. It's going to take the U.S. way too long to up that starting age to where the majority of countries in the world are at age 25. Again, change is hard. The U.S. doesn't like to change. But one of the interesting things is the task force recommends HPV testing alone in women over the age of 30. So I just told you that the vast majority of women in the United States are screened with PAP and HPV. So this is going to be another big paradigm shift of using only HPV testing. Again, there's so many arguments for doing so, and I hope by the end of this talk you will at least entertain that idea is a good one in many settings. So let's look at screening tests. Again, any screening test. What you want to do is take a population of asymptomatic people. In the case of cervical cancer, we're taking the population of asymptomatic women, and you apply the test, and you separate them out into the group that is negative for that test, usually the biggest part of that population, and the people who are positive for that test. And they get treated differently. So women with a negative screening test just come back for screening at whatever that interval is that your country and your medical societies have decided. And women with a positive test go on for additional studies. In many cases, that will be colposcopy. And with cervical cancer, we don't have that many management options. We can have that surveillance, that screening test done at shorter intervals, increased surveillance. We can have colposcopy done, or we can treat the women, usually by excision or ablation of their cervical transformation zone. And at each step of the way of our screening and management algorithms, we're getting to a smaller and smaller pool of women who are needing to be treated. And again, treatment has its downsides as well, particularly excisional treatment in women who are still of childbearing age who may want additional pregnancies and children. It can sometimes cause some problems with premature rupture of membranes, etc. So when we think about screening, what we really want to do is screen with that most sensitive test that identifies all the people in that population, so all the women who are potentially at risk. And then if that pool is too big, or if we have the resources, we apply another test, a triage test, that is more specific for our target disease that we're screening for. So in this case, it would be screening with HPV and then applying a more specific test such as cytology. Cytology is more specific than HPV testing. And then if that cytology is positive, then they get triaged on to colposcopy. And compared to cytology alone, HPV testing is quite a bit more sensitive, 20 to 40% more sensitive. It's sensitive for that target precancer, CIN3, although it is less specific. So just because a woman is HPV positive, it doesn't mean, of course, that she has precancer that needs to be treated. If we think about using HPV testing, we have to be very careful with how we choose these tests. It needs to be a test that performs as we expect it to perform. So in the United States, most of the time the rigorous method is FDA approval. So that means that these tests are supported by usually very large, very expensive clinical trials that show that that approach leads to a more efficient outcome. So there was papers that looked at the variety of HPV tests, and essentially you want something that's at least 92% sensitive for that target precancer and cancer, and it has specificity that's reasonable. For those of you who know statistics, love statistics, you know that if you increase the sensitivity, you decrease specificity. So if I had a test that was 100% sensitive for precancer, maybe I'll just test for hemoglobin. Well, 100% of the women who have precancer will be positive for hemoglobin, right? But no specificity, right? So you want to balance your sensitivity with your specificity. And in general, you need to have a clinically meaningful cutoff. Some of the tests, the HPV tests used for research purposes, are exquisitely sensitive. They're too sensitive because they reduce their specificity. So most of the HPV tests have a cutoff around about 5,000 copies of the virus. And that's highly correlated with having significant clinically relevant disease. Of course, when we're doing HPV testing, there's no role for low-risk HPV testing. Now, the vaccine, the quadrivalent and the 9-valent vaccine, prevent two low-risk HPV types, right? They prevent genital warts. And that's clinically relevant there because people don't like having genital warts. But if we're testing in the context of cervical cancer prevention, the low-risk HPVs do not cause cervical cancer. So we do not need to test for them in a screening program. And the choice is usually made by all of us in the laboratory, what test we're going to use. Maybe we're using the same company's platform for something else. Maybe it's cost. Maybe it's just space in your laboratory. But we clearly know that the different HPVs are not the same, the different high-risk HPVs. HPV 16 and 18 are the truly bad actors. If we look at women who are PAP negative and follow them out for about 10 years, women with HPV 16 have almost a 20% risk of having high-grade disease detected, compared to the women who are HPV negative, which have, 1-2% risk, 10 years out. So what HPV testing allows us is to find out the woman's risk in the present, but also her future risk, which is very different than the morphology-based interpretations, which is all in the here and now about her risk in the present. So I don't know how many HPV tests that you have available in Brazil. In the United States, we actually now have 5. Of the 4 older ones, they're all, each company has their own way of doing it, and they'll market them and say, mine is better than yours. They can be DNA tests or messenger RNA tests for the oncoproteins E6 and E7. All of the newer generation added in another high-risk type from the granddaddy of them all, which is the hybrid capture 2. Again, very different ways of getting to the same idea. In the United States, the COBOS HPV test is the one that's approved for primary HPV screening. These others are approved for co-testing and for triage of the minimally abnormal PAP, the ASCUS PAP. And then very recently, in the last couple of months, BD's product on Clarity was FDA approved as well. And that is similar to the tests that have partial genotyping, but it goes even beyond that, and it gives what's called extended genotyping. So the partial genotyping tests give 16 and 16 and or 45. The on Clarity test gives you all of those, and additional gives you some of the other high risk HPV types, and they've also been approved for primary screening. So our whole paradigm of how we've approached cervical cancer screening has changed since I started in the business. Of course, I'm going to date myself now, but when I started in the business, we did not know that HPV caused cervical cancer. Okay? Seminal work of Harold Zurhausen, he won the Nobel Prize for that. Makes an enormous difference in how we approach. And because of those discoveries that Dr. Zurhausen and others have made, we have learned so much about HPV-associated disease that we can shift our thinking about how we approach it. So we can think about shifting from Dr. Papanicolaou, who I went to Cornell Medical School, which was where every day I walked past a bust of Dr. Papanicolaou, to thinking more of Dr. Zurhausen and his colleagues, and changing our paradigm for HPV testing, and potentially with using cytology that we all know and love as that reflex test. But I'll tell you, as we move into the 21st century, there's going to be other tests that also are more objective, have less inter-observer variability than does Pap test cytology. I've talked a little bit about partial genotyping, extended genotyping with the new OnClarity test, and there will be others out there that have extended genotyping. And one of the morphology triages that it's already being more widely used in Europe is dual staining. And I believe there's actually and show you a little bit about how those might be integrated into our testing and management algorithms. So in the United States, we do a lot of co-testing, right? We do PAP and HPV. We know from that seminal ALTS trial back in the 90s that what to do with ascus. So I don't know if this will translate in Portuguese, but in the United States, cytologists say, don't ask us what ascus means, okay? It's sort of this, I don't know, it could be, but maybe not. We know from the ALTS trial that if the patient was ascus and had a high-risk HPV, that she had the same risk for precancer as a woman with low SIL on her PAP. And those patients we took for colposcopy. So we triage women with ascus HPV positive the same way we triage women with low SIL, because they have the same risk of precancer. Now, the new ascus, if you co-test, is women with negative PAP, but they're high-risk HPV positive. What does that mean? That's, a small fraction of the population, less than 10%, usually around 5-6%. But with those, we can keep them under closer surveillance so that instead of going out to 3 years or 5 years, we repeat test them in 1 year, because it's the persistence of high-risk HPV that's the true risk for developing precancer. Not just 80+% of the sexually active population is exposed to HPV during our sexual lives. So just because you have HPV doesn't mean that you have precancer. I would say it means it's a marker of sexual activity. Cool, most of us, at some point in our lives are sexually active. How do we maybe tease that out a little bit more now that we know that not all high-risk HPVs are the same? So we know 16 and 18 are the real bad guys. So with partial genotyping, we can take 16 and 18, and I'd say 45. 45 is a relatively rare HPV type, but it's also associated with a significant number of cancers. Not as many high grades, but more cancers. So we can take those bad actors, and those women can go right on to colposcopy, while if they're positive for some of the other high-risk HPV types, we keep them at closer surveillance. But if they're negative, then they just go on to routine screening. And when we do that, we see that we take about 5% into increased surveillance of that overall 6.7%, and a little over 1% of those women get triaged to colposcopy. But the amazing thing is, we find in this pool of women who are PAP negative HPV positive, we find 2, 3, 4 times as much high-grade disease in the women who are 16, 18, or 45 positive as compared to the 12 other high-risk HPV positives. So we're continuing to use our more sensitive tests first and triaging with more specific tests so we get to women who are truly at risk for precancer or cancer. But how about if we eliminate the cytology up front? Sorry about that. In the first place. So if we're doing primary HPV screening, and we're using both partial and or extended genotyping. Here first with partial genotyping, we can, whoops, too many buttons. We can take the women who are 16, 18 positive on for colpo. We don't know what their path was, but we know the 16 and 18 positive women are at highest risk. If they're negative, they can just get repeated. But now the new intermediate zone is the women who are high risk positive, but we don't know what their PAP is because we didn't do a PAP. Here we can do the reflex cytology, and if they're ascus or higher, so ascus HPV positive, would go on to colposcopy. And if they're PAP negative, they would just go in the increased surveillance. And if any of those tests are that you repeat on surveillance are positive, then they'd go on to colpo, particularly if they're HPV positive and that persists. That's the risk for being at higher risk for an HPV-associated lesion. And this is what in the United States is the approved algorithm for the 2 HPV tests that have been approved for primary screening. I might add the FDA-approved algorithm is at 3-year intervals, when that task force recommendation was for HPV testing at 5-year intervals. So those are just draft recommendations. We do not yet know what the final task force recommendations are. But there's, of the people, the associations, groups that set the standards for cervical cancer screening, the task force and the American Cancer Association are the 2 main bodies that set the screening recommendations. So this may really change how we approach cervical cancer screening in the United States. Even though we have those 2 tests approved for primary HPV testing for screening, we have very little uptake of it as of now. It's taken a long time to get people on board to switch from yearly PAPs to 3 yearly PAPs to co-testing every 5 years. And if you start taking away things, it makes the change even harder. So if we take away the PAP or we take away the frequency of screening, people will feel like they're being shortchanged, rather than it's based on our best science. So in the future, primary HPV screening will be using triage to colpo if they're 16, 18 positive, reflex cytology if they're high risk but non-16, 18 positive. We may be using some other test, such as that extended genotyping. I haven't talked about methylation. There's no commercially available methylation test yet, but that's one of the ones that's going to be really interesting coming up, because that can help separate out whether you have precancer or non-precancer. And then I want to touch briefly on dual staining, which is again a morphologic-based triage test. So with extended genotyping, we take into account those other HPV types. And if they're high risk positive for any of those other than 16 or 18, we need to keep them under tight control. But can we tease out from those 5, 7 that are high risk and do something else? And the answer is probably yes, because we'll have persistence data. So we'll know if someone is HPV 33 persistent, and that would put her at higher risk for true disease, as opposed to a woman who's 33 one year and the next year she's 52 positive. Probably not the same risk. For dual staining is an interesting morphology-based test. It's based on the fact that cells should not be both P16 and Ki67 positive in the same cell. So P16 is a surrogate marker for the transforming effects of high-risk HPVs. It's also something our own cells normally make. It's actually an oncoprotein, and it's paradoxically overexpressed when the high-risk HPVs sort of take over our cells. Usually it's a marker of senescence, so things that stop going through the cells that have stopped going through the cell cycle. So if you have that, if you're positive for P16, but also for Ki67, which is also known as MIB1, which is a proliferation marker, the same cell shouldn't be saying go to sleep and divide at the same time. So if you have cells that are staining with both of those markers, again, it's a reflection in this context that the high-risk oncogenic HPVs have transformed the cells, have taken over our cell cycle machinery. And we can use that both on cytology or histology. Here, dual stained on both cytology and histology. This is a positive P16 stain in the brown to be supportive of a diagnosis of high-grade SIL on histology. You need what we call block staining. So from the basement membrane, the basal cell layers, at least 2/3 of the thickness of the epithelium, not patchy staining. That doesn't make a positive P16. When you're looking at cytology, you want the staining is actually, the P16 staining is both in the cytoplasm and in the nucleus, but if the Ki67 is the red chromophobe or chromophore, and it overcomes the brown. So cells should not be positive for Ki67 and positive for P16 in the same cell. Highly correlated with the presence of colposcopically directed biopsies that will show high-grade SIL. So as we get more and more options for screening and triage, we're going to need to integrate all of these. And your patients, if they're anything like what they are in the United States, may go to one doctor one time, another place, another doctor another time, and have different tests available to them. So we're going to need to be able to integrate all of these different findings. So being positive for dual staining puts you at a higher risk. If you're non-16/18 high risk positive, so go on to colposcopy. So if we think about all of these different changes that are happening in the field, great changes, fantastic changes, but it makes for a lot of confusion. Clinically, we still only have a couple of different ways of responding. We can look at them with increased surveillance. We can take the patient to colposcopy. We can treat. So all of these combinations of tests, if we think of them as their risk for high-grade lesion, for a precancer or cancer, will help make sense. Again, it's, if when I'm seeing a patient in clinic and I did colpo for 25 years, those were the only things I had which were possible. I could see her more often, see her back, see if she had a lesion that progressed or went away. If I didn't find high-grade disease on her colposcopy, I could try repeating the colposcopy, doing more biopsies, or I could treat, particularly if she had a high enough risk cytology, and particularly if she was past childbearing, so that she wasn't concerned about the risk of LEEP or excisional biopsy on future childbearing. But our clinical colleagues often look at all of these different test results and they go, oh my God, I don't know what to do with them. And so one of our roles as cytologists is also to help make sense and integrate all of these different results so that our clinical colleagues will have a clearer idea of how to proceed best for their patients. And it's always based on the concept of similar management for patients at similar risk for precancer or cancer. So again, things are changing, but also remember that we're using HPV testing in a variety of different contexts. We use it in screening, which we've talked about, triage, which we've talked about, but we can also use it in the post-colposcopy and post-treatment management to see if our patient is, quote, cured, I'll put that in quotation marks, and or can return to regular screening. So the really rapid evolution of changes that has been confusing to us as cytologists and our clinical colleagues alike, but it's based on really good evidence, really good science. And as we progress, we're going to have more and more different choices to integrate into our screening and management recommendations. So with that, I feel that my role as a GYN cytologist is becoming less relevant, and I'm both sad about that and very happy for the future, because I think we'll be having amazing results, and maybe at one time in the future we won't need to screen for cervical cancer at all. Wouldn't that be the best of outcomes? So with that, thank you.